This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Southerland again from the University of Virginia. And for this week's Neurology podcast, it is my great pleasure to be speaking with Lidia Moura, Associate Professor of Neurology at Harvard Medical School, Director for the Center for Value-Based Healthcare and Sciences at Massachusetts General Hospital, and Co-Director for Healthcare Intelligence at Harvard Business School. For this week's podcast, we're going to be discussing an article recently published in Neurology titled Implications of Large Language Models for Quality and Efficiency of Neurologic Care, Emerging Issues in Neurology. In this study, Lidia and her co-authors discuss the integration of these large language models, which we'll talk a little bit more about, obviously, and define in the content, but the integration of these models into neurologic practice, including the benefits, challenges, and importantly, the potential biases we all need to consider as this new technology rapidly advances in our patient care. So first, Lidia, thank you so much for joining us for the podcast.
Thank you for having me.
Let's dive right in. This is not a bread and butter neurology topic, but it is so important to our practice, both present and future. Could you just tell why this is an important topic and maybe even offer a brief definition of what these large language models are that folks should be aware of?
Our discussion is crucial because it highlights how large language models, or LLMs, revolutionize clinical care in neurology. They are softwares or programs that they can analyze vast amounts of data and generate outputs that can be very useful for clinicians. And they have the potential to enhance efficiency, improve patient outcomes, and streamline many aspects of our daily practice. However, they also have unique challenges that we must navigate very carefully. And understanding both the potential and the pitfalls of LLMs can help neurologists make better decisions about incorporating these tools into their practice.
Okay, great, Lidia. That obviously is compelling, and I think we're all hearing about this not only in the field of healthcare, but also in the public arena as well. Can you just briefly summarize what are the major tenets of this particular paper that you all read?
Sure. Our research highlights the significant potential of those models in clinical neurology. And I'm going to outline a few of the major findings. The first, and I think it is the most important, it is on clinical documentation. LLMs can generate accurate and comprehensive clinical notes based on audio recordings of patient encounters. And this can streamline documentation processes. The other very important highlight, it is the data review and summarization. They can really efficiently read vast amounts of chart data and summarize that, for example, for a discharge note. And this could make it faster and quick to get, for example, patients discharged and also to make decisions. Automated communications. So they can automate communications between multiple stakeholders, for example, payers and providers in prior authorization processes. Also, patient portal communication. So large language models, they can enhance the provider and the patient interactions. For example, by reading those many in-basket messages that we get, it can categorize, it can even suggest some responses. And in the future, it might even help us respond on our behalf. And it can also route that to the appropriate provider, for example, if it is just a refill, if it is just a message for IN or an NP, it can help direct the messages to the right provider. And this is a huge advancement to our practice. It also can help administrative tasks. For example, LLMs, they can be used in transcription, revenue cycle, mapping of processes, and even suggesting ways in which you can make care safer and more efficient.
Certainly, the menu of things that LLMs seem to be able to offer this promise is very enticing. I can speak certainly personally as someone who struggles with all these aspects of clinical efficiency, documentation, administrative tasks, triage with our team in the clinic. We're all similar in this challenge as we try to focus on that doctor-patient relationship. Let's just start with the clinical documentation piece first. This is something we're all behind on our notes. We're all at home at night trying to take care of our family and waiting till they all go to sleep to write notes. So how can LLMs actually improve this process? How can they make us more efficient with our clinical documentation?
This is one of the most exciting aspects for me. As a mother of 2 young kids, I used to be writing my notes on a Saturday morning, and now I'm actually helping grow a strawberry field. Clinical documentation, LLMs, they have been integrated into what we call ambient AI. This involves a device that would record the encounter and then transcribe the note. And then the LLMs, they can reduce the time clinicians spend on documentation by generating a very well organized clinical note for them. And then this means that we can spend more time to focus on our patients, to interact directly with them and maintain eye contact. Essentially, while we can provide neurological care, they are listening, they are processing the conversation, and they are creating that very long and detailed note that we need for our future encounters, but without taking 30 minutes or 60 minutes of our lives. And this can also free up the time of other providers and other clinicians that they are taking care of those patients as well. So that's not just for a neurologist, this is for everybody providing clinical care that would otherwise spend lots of time typing. They now can spend time touching their patients and taking care of those who need us.
That sounds amazing. I've heard a little bit about this. We've not started using it in my clinic yet. So I'm really curious how this actually functions and point of the patient encounter. I believe you're a neurophysiologist, epileptologist. So give us an example of how this might work, seeing one of your patients presenting with seizures in the clinic, for instance.
So imagine in a follow-up visit, taking care of someone with epilepsy, I would ask questions about my patient's recent seizures, their current medications, any side effects, and I could go on and on. And the conversation could go in many different directions, right? They would give me very much details about what they had for breakfast, and then they can keep going on these tangentials, and then also with embedded important information. And as this conversation happens, the LLM-based tools, they would listen and generate a nice and objective note that includes only the relevant information of the encounter. And this note can be viewed and finalized by me or the neurologist or whoever is taking care of the patient before it is signed in the electronic health records. So one interesting feature is that it's not just a transcription. It does a very nice job at analyzing the conversation and removing the irrelevant information. So if it is something about if someone bangs at the door or someone interrupts and gives an information that has nothing to do with that specific encounter, it would remove that and it would organize into a format that we prefer. For example, I have tested a very few solutions, 2 or 4, and many of them would organize the notes in sections like history of present illness, physical exam, assessment, and then plan. And it would do that without me telling them. So they realize what I'm doing, and it would put that into the note, understanding what I'm doing in the visit. And some of them are also now trying to put that into common themes and problems. For instance, in my encounter for epilepsy care, you might see the assessment and plan organized into sections like coordination of care when I'm trying to reach out to the psychiatrist to help convey some screening for mental health. It might also organize into anti-seizure drug medication adjustments, and it can also break down by rescue medications versus maintenance medications. So it helps me not only organize my thought process, but also the plan and the action. The most exciting things about that is it is really fast. It generates in seconds to a few minutes, and this is really groundbreaking because in the past, I would spend, let's say, 10, 20 minutes typing a note of an encounter that lasted, let's say, 30 to 50 minutes. And now this note is signed and finalized within the encounter time.
This certainly must be too good to be true, Lydia. This is something that we all want to start immediately in our practice. So let's talk a little bit now about the challenges, okay? Clearly, everyone's thinking, okay, this might work in somebody's clinic, but for me and the way I interact with patients, it's going to perhaps have issues with accuracy, or maybe it's not reliable. I'm going to have to do a lot of heavy editing. Can you talk a little bit about how the models work in a real clinical practice setting, and what are some of the challenges and things that we can overcome to bring them into practice?
Yes, I often say to my students that it is amazing, but it's not magic. Yes, it can make mistakes. It can produce very odd outputs. In my experience, a very common mistake, for example, in the clinical practice is the incorrect spelling of people's names. I have seen Dr. Smith. That is an easy one, so the LLM would pick up nicely because it's a very common American name. But if it is Dr. Indian name or Dr. Brazilian name, which is something that has not been very common in the training set, it would come with very different spelling. For example, in my case, Dr. Moura, it's almost 99% of the time there's Maura, or Lidia with an Y instead of an I. And that is not, let's say, a safety issue, right? In rare occasions, I would see a safety issue, and that's what worries me a lot. A doctor might say, I will prescribe you 4 milligrams of a drug. But the note comes back and instead of 4 milligrams, there is 40 milligrams. That extra zero on the right might be just a small typo for an LLM, but it's life-threatening if this becomes, let's say, an automatic order, and if the patient actually uses that. So these mistakes, they could be very dangerous in the healthcare setting. We're aware of that, and we need to create mechanisms to evaluate for that. The LLMs they often lack a deep understanding needed for clinical reasoning. So many people are talking about, can they really think like a doctor? They can really make a diagnosis, a differential diagnosis, for example. Some would say, some papers are coming out saying, yes, they can do in multiple different ways. Others, they would say, no, it's not what they do. And in the paper, we show the evidence against and in favor of those arguments. But the bottom line is that it can misinterpret the patient's symptoms if they are described in an unusual way, and it can lead to an incorrect documentation.
That seems to self-evident. All that glitters is not gold, particularly with new technology. And any of us who even voice text on our phone know that the spelling oftentimes is benign, but in the setting of a clinical encounter, particularly if that documentation is going to be relied upon for action, as you point out, with the medication dosing possible error, it's going to require heavy human oversight. A lot of variability, a lot of complexity in neurologic care. In your paper, you talk about some very specific strategies to deal with some of these issues of variability, complexity, and then, of course, the importance of making sure we don't encourage bias either in the outputs, and then recognize that there are natural biases in the training sets as well that make up these LLMs. So briefly, if you would, Lidia, just go through a few of those very specific ways that we can mitigate some of these challenges.
Absolutely. LLMs are trained on vast, really huge amounts of text data, which makes them really nice in trying to recognize multiple different patterns and generate very interesting and relevant text. However, as real life is different sometimes, and not every patient read the book, right? So let's break this down. The first piece that we need to be very aware of is nuances and variability. So real-world clinical data is highly nuanced and variable, and different clinicians might describe the very same condition in very different ways. And then the patients, they might also present with atypical symptoms. Imagine someone describing a temporal lobe seizure. That description can be highly variable depending on your background, your age, your beliefs, your English proficiency, and so many other things, and even the seizure itself, right? What the patient is describing, how the physician is interacting with the patient might not match exactly the patterns in which the LLM has been trained. And this can cause some variability in the output, which can lead to some unreliable outputs. And we need to understand in which ways this could be harmful or acceptable. The second really important point is specific biases. So one of the major limitations of LLMs is the risk of having a tendency for generating certain specific outputs that would give minorities or specific subgroups a disadvantage. So biases in the training data can lead to bias in the outputs. And that is the very famous trash in and trash out, one of the common examples of that. And for example, if a data set do not represent a specific ethnic or demographic group, the resulting model may show bias against these populations. They might not even believe that a specific safety recommendation might be applicable to that group because they have never seen that in the training data. This could be really bad consequences for those populations, and it can affect medical management, public health, and even compensation programs based on the recommendations and the best practices, right? So imagine that an output is rewarding people for providing safety recommendations for the white and not for the Latinos, and rewarded to favor providing better care to a specific population. I'm going to emphasize a behavior that is going to just make it worse and worse. And then the perpetuation of these biases can even make inequalities worse. The third aspect of that is monitoring and evaluation. And that brings back to our roles. And every neurologist play a role in this field, which is to monitor and evaluate the performance of LLMs in the clinical setting. We are a big, important stakeholder in this field. And then we need to regularly assess to ensure that those models are functioning correctly and not reinforcing biases. And it's important that we are who we are. We need to involve diverse people of all kinds to evaluate those and then to bring their voice and to recognize the issues the way that they see. And then that diversity is what's going to help improve those tools over time.
I think those are really salient points. I think that we all have some general awareness of the importance of this challenge. We certainly don't want to take a tool for one intended purpose and then create or exacerbate a disparity in care. And that constant monitoring, evaluation, both of oneself and also of the technology, is going to be so crucial as this becomes more prevalent in our practice. So bringing it back home to the practicality and maybe even getting to our sort of summary here, we've talked about the promise of these tools. We've talked about the pitfalls. As folks are listening to this and maybe they have varying degrees of awareness or access to these LLMs, how can people think about actually integrating this or using it in their practice, whether it's in a community practice, hospital setting, an academic department, et cetera? What are some key points about and resources that people could seek to actually integrate these tools?
I would say every time I give a talk about clinical documentation efficiency with AI, that is the key question because they want to use that at the next clinic day they have. And I need to talk about the 4 buckets because I think those are critical to keep patient care in a safe place. The first one is to avoid using publicly available versions of those LLMs. So if you Google, you're going to see multiple offerings, and many companies are now offering those solutions out there. But integrating that into clinical flows can be dangerous because it might violate patient privacy. I would say avoid, just start using whatever is out there that is publicly available and try not to put patient information into those prompts. For example, even though you might think that a piece of information here and a piece there might not be enough to identify a patient, if you actually imagine that on the back end, these LLMs, they are storing and integrating, they might, at the end of the day, identify who this patient is. So little pieces of information here and there, they might be enough for an LLM to make the whole story or even create a new story that might not be ideal for you. The second bucket, it is the seeking help, i.e. department guidance. So if you are in a neurological practice, it could be very small, it could be very large. There must be someone that is responsible for buying those tools, right? Except if you are a solo practitioner, and then we have a specific guidance for you in the paper as well. But seek guidance, right? Institutional IT department are knowledgeable and they are seeking expertise help on how to evaluate those tools, how to fit those tools into the healthcare regulatory environment. And they are responsible for making sure that the LLMs are going to be available to you in a compliant manner. The third bucket, it is awareness of bias. You talk to me, I'm going to raise the flag of bias because we should all acknowledge that these LLMs, they might have biases, and it depends a lot on the training data. It also depends on the user, right? Because if the user is completely agnostic and doesn't really monitor for the biases, even a minor thing can be exacerbated by misuse of an information. So being conscious and vigilant against outputs that they may have, for example, racial or inequitable implications is a big important step before using that in clinical practice. Point number 1 and 2 is making sure that you use that safely, you seek help, and 3 is making sure that you use that in a responsible way. And then the 4th point is review it before you sign it, right? If someone is writing a draft of a letter of recommendation and ask you to sign it, you're going to read before you sign, or before you buy something, they give you a contract, you're going to read what you sign, right? Please read what you sign. And because that could be the key to prevent those very rare but very big mistakes that LLMs can make.
I think that 4th point is so critical in our high throughput environment, whether we're been practicing for 20 years or a trainee in our residency or new to our clinical practice. There's such pressure to rapidly get through your documentation and making sure that you review things and don't leave errors is a balance between efficiency, time, quality of life, and providing good, accurate patient care. So I tell you what, Lidia, we could continue to go on and on. There's so much in this paper, so much on this topic that needs to be discussed, needs to be socialized in our field. I think we've run out of time for today. Just final thoughts. Tell our listeners where else they can go to seek resources. I know that there's a lot of good information, for instance, at the Academy's website, and you're on some of those committees as well. Where can people go to find more information other than, of course, reading the paper?
Engagement and communities of people that are interested in sharing and talking about that. So AEN has the Synapse page, Community of Practice on AI. Quality Informatics Subcommittee is really fun, and I encourage you to potentially sign up to be a part of one of those groups. Online resources, AN.com is launching a clinical informatics tab under practice. It's going to be amazing, and it has a lot of very useful information. Neurobytes, another version of knowledge that is brief and digestible. I also encourage everybody to come to the AEN conferences. We have prepared many courses and offerings in practice hubs and short talks at the AEN Fall in Las Vegas, and then the AEN Spring Conference in San Diego. Please come. My final thought, and I think this is my really important message to you, is that you don't need to be an AI expert to evaluate AI tools. I realized that when I was watching my son playing with a chatbot, and then he was asking it to generate animals playing Uno. But then he was frustrated because he realized that very fancy and famous chatbot was not generating the output that he would expect based on the rules of playing Uno. And he was right. My 6-year-old can evaluate a very sophisticated AI tool. Why I cannot evaluate a tool for neurological clinical practice? As a neurologist, I am the expert, and I am the expert that is qualified to tell whether tool A versus B is most or less appropriate for my clinical practice. So I encourage you all to do the same. Use your expertise to leverage and to also evaluate those tools in your field.
I think that's a great way to summarize this podcast. In essence, saying use these tools. Let's use them smartly, safely, so that we can have more pajama time with our kids, less on our documentation, so we can correctly play Uno and less time on a computer. I can tell our listeners that none of this podcast was created with the help of a large language model. This is all human generated from neurologists out there. And I really encourage you, please seek out this manuscript, Implications of Large Language Models for Quality and Efficiency of Neurologic Care, Emerging Issues in Neurology, for a lot more than all that we've just covered here today. I want to thank again Lidia Moura. Thank you for joining us for today's podcast, and we look forward to learning more and hearing more from this ongoing work.
Thank you for having me.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.